Hello everyone, my name is Cynthia Lee and I am a third year medical student at the Kirk Kerkorian School of Medicine at UNLV. And today I will be discussing a novel double layer undermining technique for the closure of large scalp defects. So large scalp defects, they present a challenge to most surgeons. The skin of the scalp is very tight and is not as elastic as skin elsewhere on your body. So if you can go ahead and pinch your forehead, that skin is very hard to grasp compared to skin elsewhere on your body, let's say on your hand, which is easier. And this presents a challenge, right? Because it's more difficult to close a wound. And the surgical objective is to maintain functionality, but also to close the wound in an aesthetically favorable manner. So going back to Mohs micrographic surgery, or Mohs surgery for short, it's a conservative procedure to treat skin cancer. Skin cancer is more than what you can visualize on the surface. Think of it more comparable to an iceberg. A lot of the cancer is embedded under the surface of the skin, and as you can imagine, you're cutting away more of that cancer-containing skin and leaving a bigger wound than anticipated. Mohs surgery involves thin layers of cancer-containing skin, which are progressively removed and examined via a microscope until only cancer-free skin remains. The procedure is precise, but it can also leave a large wound depending on the thickness of the cancer. Standard modalities of wound closure include tissue grafting and large flap closures, as you can see in Figure 1. This is the example of a large flap closure, and although they usually provide good coverage of the bone, the downside is that they are difficult to execute, difficult for the patient to tolerate, and may add long lines of scarring and alopecia. Wounds, they heal the best with linear closures. However, this is limited by lack of tissue elasticity of the scalp. So in our methods, we had a case series of 28 consecutive patients. We investigated the double layer undermining closure technique for medium to large scalp defects following Mohs surgery. And we refer to scalp anatomy. The deepest layer is the skull, overlaid by the pericranium, loose areolar tissue, the Galilea aponeurosis, the subcutaneous tissue, and then the skin. So with this technique in Figure 2, it's all about improving it's all about improving tissue elasticity in the underlying structures. This includes making the wound a little bit bigger before we do the undermining, which increases skin elasticity. So right here, it used to be a circular wound, and we kind of created like dog ear flaps right here. So we cut away part of the wound to make it a little bit bigger to increase the skin elasticity. So after we accomplish that, in the first picture right here, the forceps are latching onto the Galea aponeurotica. This is the first layer of undermining. And we place dissolvable sutures, drawing in the tissue and holding in most of the tension. The second layer of undermining is with buried vertical mattress sutures in the subcutaneous dermis plane, and we approximated the wound edges as shown right here. Finally, running epidermal sutures are placed, which are not shown, but we would just have sutures right here. And you can see in the last picture, the overall healing process was very excellent. There was virtually no scarring for this patient. For our results, the average minimum and maximum wound diameters are 2.39 and 2.93 centimeters. The mean subgaleal undermining, which was the first layer of undermining, was 4.2 centimeters. The mean subcutaneous undermining was 1.3 centimeters. The mean galeal gap, which is the open area not able to be closed by galeal sutures alone, was 0.8. And these numbers, we want these values to be as small as possible. This means greater tissue elasticity to close the wound. Focusing in on some of the complications, we had wound edge necrosis in 2 patients, and even though we had wound edge necrosis in these 2 patients, there was overall excellent healing, and there was minimal scar, atrophy, spread, or alopecia in these patients. So in conclusion, double layer undermining can be used for linear closures of the scalp in order to create additional elasticity and successfully close difficult defects. Double layer undermining can be pre-planned and executed before sutures are placed, or it can be performed after a wound cannot be completely approximated by galeal sutures alone. For future directions, we plan on incorporating more patients and ascertaining the largest scalp defects that we can close with this technique. And that concludes it. Thank you for your time.